All right, welcome to The Explainer. Today, we're going to do something a little different. We're going to play medical detective, diving right into a clinical case file to solve a really fascinating diagnostic puzzle.
So it all starts with this, a single, pretty terrifying sentence from a patient. Just imagine that for a second, waking up and realizing you can't control a part of your own face. This is our first clue, and it's a big one.
Okay, so here's the scene. We've got a 35-year-old woman, totally healthy one day, and the next, one side of her face just stops working. No accident, no injury, no obvious reason. This is where our investigation really kicks off.
Now, every good investigation starts with the initial report, right? So let's break down the clues the patient gave us when she first walked in the door.
So these are our first critical clues. The keywords here are sudden and one-sided. And it's serious. She can't even close her eye. But you know, what's just as important is what's not on this list. No trauma, no recent infections. That tells us right away that this probably isn't from an external injury. The problem is coming from inside. All right, we've got the initial story. Now it's time to bring in the forensics team. Let's look at the hard data from the physical exam and the lab tests and start figuring out what's really going on here.
First up, the vital signs. And immediately, we kind of hit a wall. Her blood pressure, a perfect 120/80. So we can pretty much rule out a hypertensive crisis. What about her heart rate? Also a nice, steady 72 beats per minute. That makes a major cardiac event seem really, really unlikely.
Her breathing is just as calm and regular, no signs of distress at all. And her temperature is completely normal. No fever. Which means a big, system-wide infection is probably off the table. Now, this is a huge clue in itself. Having all these normal vitals tells us this isn't some system-wide failure. No, this is a very, very localized problem. The mystery just got deeper.
Okay, since the vitals were a dead end, we need to go right to the source, the brain. An MRI is ordered so we can get a look at the body's command center and rule out some of the most dangerous suspects. And here it is. This is the critical turning point in our investigation. The MRI comes back completely clean. No sign of a stroke, no tumor, nothing. Now that is fantastic news for the patient, but for our investigation, it means our biggest suspects have just been cleared. The blood work basically confirms what everything else was pointing to. Her red cells, white cells, platelets, all perfectly normal. This rules out things like a major infection, anemia, or some kind of clotting disorder. So at this point, the evidence is overwhelming. This is not a stroke, it's not a tumor, and it's not a systemic infection. We're running out of bad guys. Okay, we've followed all the clues, we've analyzed the evidence, and we've ruled out the major threats. Now it's finally time to unmask our culprit. So let's just recap for a second. We have sudden, one-sided facial weakness, we have normal vitals, a totally clear MRI, and perfectly normal blood tests. So what condition fits all of those facts? The diagnosis is Bell's palsy. This is a classic example of what's called a diagnosis of exclusion. It's like we've eliminated all the other possibilities and what we're left with is a perfect match for the patient's symptoms. Sudden, one-sided facial paralysis.
But hey, with a diagnosis of exclusion, you have to be absolutely sure, right? So let's just double-check the evidence and confirm exactly why our other suspects got ruled out.
A stroke was definitely our #1 suspect, but the evidence just doesn't fit. A stroke bad enough to cause this kind of facial paralysis would almost certainly bring accomplices, like arm weakness or slurred speech, and it would have left a clear footprint on that MRI. Our patient had none of that.
So, what about multiple sclerosis? Well, MS can affect the facial nerves, but it rarely works alone. We'd expect to see other neurological symptoms pop up, like vision problems or numbness in other parts of the body. Again, it just doesn't fit the facts of our case.
Now, this comparison is super clear. Trigeminal neuralgia is all about sensation. It causes these episodes of severe, stabbing facial pain. Bell's palsy, on the other hand, is about motor control. It causes facial weakness. Two totally different problems affecting the same area.
And finally, an acoustic neuroma, which is a type of tumor on the hearing nerve, that was ruled out too. Its main symptoms are hearing loss and ringing in the ears. Our patient had neither, and besides, the MRI would have definitely spotted it.
So there you have it. Case closed. We followed the evidence all the way from the very first symptom to the final diagnosis. Let's just quickly review the big takeaways.
The key takeaway here is this. Bell's palsy is really defined by that sudden, one-sided onset. The diagnosis comes from recognizing these classic symptoms and, this is crucial, using tests like an MRI to rule out much more serious conditions like a stroke or a tumor.
And that leaves us with one last really fascinating question. We know what it is, but we don't always know why it happens. Bell's palsy is thought to be caused by some kind of inflammation of the facial nerve, maybe triggered by a virus. But in so many cases, the true cause, it just remains a mystery. It's a great reminder that even in modern medicine, some cases are, for now, officially closed, but not entirely solved.